Good afternoon. Thank you. First of all, thank you for the meeting organizer to invite me here, actually to bring me to be aware of this great course. I think great course. This is my first time to Africa, and I think this is something very great we're doing. So, thank you. Next, I'm going to talk about the role of radiotherapy in the management of esophageal cancer. Actually, I was just looking at the poster outside, and the esophageal cancer based on the Tanzania tumor registry actually is number one. So, obviously it's a very, severe, serious health hazard. And esophageal cancer is one of those cancers, even though, the incidence is not as high as like a prostate or lung cancer. However, the death rate, the mortality rate is as high, almost as high as the incidence. So, meaning that this disease is killing people very quickly. So, in North America, in Western countries, there has been an increase in adenocarcinoma. However, squamous cell carcinoma still remain to be endemic in a lot of areas in Asia, in Africa, and also in Middle East. I think everybody has seen this map many times, so I'm not going to go over too much. But the only thing I want to say is, esophageal cancer. Is 8% of all cancer diagnosis, but obviously, I think from the tumor registry, it's probably higher. And squamous cell carcinoma or adenocarcinoma of the esophagus, actually, their the risk factors for those two histology is different. You can see that squamous cell carcinoma actually is highly the risk factor, including smoke and alcohol use, and also a lot of factors that are related to irritation or burns of the esophagus. However, in the adenocarcinoma, it's more acid reflux, obese. So the histology is different, and the etiology probably is a little different as well. In terms of diagnosis of esophageal cancer, of course, we started with barium swallow. I think in a lot of developing countries, barium swallow is still a very important staging or diagnostic method, and in the endoscopic scope examination. And during the endoscopy, the most important thing is we need to do a ultrasound examination, because esophageal cancer is staged according to the depth of its invasion. So the ultrasound is the only modality actually can tell you the depth of the invasion. Of course, if it's available, PET scan is always very helpful in not only detecting the location of the tumor, but also sometimes the lymph nodes. For example, this patient has a small lymph nodes, in the upper thoracic. A CT scan for radiation oncology, of course, is very important, because we're always based on our planning on CT scan. Even though we take all other information into consideration, CT scan is the key. And this is another very typical cause of this is a middle thoracic esophageal cancer. This is an upper thoracic or almost like cervical esophageal cancer, typically squamous cell carcinoma, and often seen in Asia, in Middle East, and in Africa. And you can see the thickening of the esophagus. And this is actually very typical what we see in North America, distal G junction tumor, and with the thickening in the, close to diaphragm. So the AJCC staging system of the esophageal cancer was updated in 2010, but the principle of tumor staging has not changed, still based on the depth of the invasion. However, what the biggest change is, instead of the regional lymph node, as AJCC staging system version 6. In this version 7, the number of the involved lymph nodes was the base for nodal staging. So 1 to 3 lymph node is M1, and more than 3 node is N2. Please realize the limitation of the new staging system, because the only reason they can stage this nodal disease very accurately is by patient. They look at the thousands of patients, about 5,000 of patients. They all underwent 3-field esophagectomy and 3-field nodal dissection, and then they counted the positive lymph node. However, when you before treatment, when you want to stage nodal disease, when patient has not had a surgery, obviously the nodal staging is not going to be accurate. So the staging system actually is based on pathological staging. However, we're going to use that as a preclinical, pre-treatment evaluation. So just realize that limitation. Now, what is the goal of treatment in esophageal cancer? I think for any cancer or any solid cancer, the goal of the treatment is render patient cancer-free. So if a patient has surgery, it has to be R0 resection. If a patient had a chemoradiation, there has to be complete pathological response. If you have not achieved this goal, that means your treatment is failed, because patient is not cancer-free. So, but what we have found is, surgical surgery alone, 5-year survival is really not that great. Chemotherapy alone, I have never seen a chemotherapy cured any esophageal cancer. Radiation alone, very low 5-year survival. So single modality for treating esophageal cancer pretty much has been outdated, and combined modality is considered the standard. So I will start with the surgical treatment and talking about why we have added neoadjuvant chemo and chemoradiation. So this is a graph to show you why R0 resection is important. You can see if a patient had surgery, and after surgery, if they had R0 resection, their survival is pretty good. If they had R1, meaning that they had the positive margin, their survival compared to patient who did not have a clear margin is significantly inferior. If a patient had residual tumor, then of course their long-term survival is pretty much impossible. And if you look at those these 3 lines, there's not too much difference. So that's why R0 resection is very important in esophageal cancer, I think in all solid tumors. And if you have a positive margin after the surgery, basically patient has failed. So this is actually a table to, that's the reason, since the R0 resection is so important, and it has such a big impact in survival, that's why surgeons start adding neoadjuvant treatment, hoping that we can increase R0 resection of the esophageal cancer. So this is a table to summarize all the phase 3 studies that compared chemotherapy plus surgery versus surgery alone. So you can see that we had a number of the studies and the patient number, and you can see that there are some studies that actually demonstrated chemotherapy plus surgery versus surgery alone increased survival. You can see that. And also, in the majority of the studies, chemotherapy actually improved the survival. However, if you look at one of those representative study, from Europe, you can see that this is the chemo surgery group. That's surgery group, and that's the total patient number. So you can see macroscopic complete resection, R0 resection in the chemotherapy versus chemotherapy plus surgery versus surgery alone arm. Actually, there is no difference. And the R0 resection is about 54 to 60%, which means 45 to 40% of patients has failed already. So that's really the message. So there is a high lateral margin positive. So you can look at this. You know, the lateral, you look at the positive margin, the lateral margin positive in the chemotherapy plus surgery with surgery arm, they are about the same. So these are those are the locations, you know, if the patient did not have a R0 resection, they can fail quickly. And in this study, also what they found is that induction chemotherapy increased the survival in patients with adenocarcinoma, but not in patients with squamous cell carcinoma. So how can we further increase R0 resection rate and reduce the positive margin rate? So that's why radiation plays a very important role. That's why radiation is introduced into the neoadjuvant setting and play a very important role in the esophageal cancer treatment. So this is a actually most recent published study in 2012. In this study, they included squamous and adenocarcinoma of the esophagus as well as large cell. And they had certain criteria for tumor size and the location, chemotherapy, and then radiation therapy was 41.4 gray at 1.8 gray per fraction. After that, in 4 to 6 weeks, patients go after have surgery. So in this study, you can see chemoradiation clearly improved the survival compared to surgery alone in this group of patients. And more interestingly, in this study, chemoradiation therapy not only increased the survival of adenocarcinoma, but also squamous cell carcinoma. So this is an important point about this study. So for chemotherapy alone, probably only adenocarcinoma patient will benefit. However, in, if you give concurrent chemoradiation therapy, both squamous and adenocarcinoma patient will benefit in terms of survival. And the reason for that, I believe, at least, you can see that, in patient who had concurrent chemoradiation therapy as a neoadjuvant treatment, about 70% of them actually do not have any positive lymph node. However, if you only do surgery, they have about 30% of patients have positive lymph node. R0 resection, 92% versus about 60-70%. So this has not really changed much. However, if you add concurrent chemoradiation therapy, you certainly improve the R0 resection rate. And if you look at other risk factor, the treatment, actually the treatment itself was always a, I don't see that. Chemoradiation therapy and the surgery, and the surgery alone, you can see, a lot of risk factors favor the chemoradiation therapy followed by surgery. So this table actually summarizes the phase 3 studies of adjuvant chemoradiation plus surgery versus surgery alone. And there is, well, 1 or 2 studies maybe didn't show any difference. One is a very early study, and this one study, but most of the others, majority of the studies actually show a survival benefit. Of course, because this study was most recent, and I guess, in our institution, we kind of consider this is standard. That's why, if a patient is resectable, we always give preoperative chemoradiation therapy. So in terms of the concurrent chemoradiation therapy plus surgery versus surgery alone, as I just talked about, survival benefit show in recent phase 3 study and the meta-analysis. And the reason for that is that there is a higher complete pathological CR rate and a higher N0 rate and a higher R0 resection rate. And actually, the patient treated with neoadjuvant chemoradiation, their failure pattern has changed into a distant metastasis instead of local recurrence, because local recurrence has been actually a major pattern of the failure in esophageal cancer treatment. So how about the adjuvant setting? You know, as far as I understand, in China, in those endemic high instance of squamous cell carcinoma areas and regions in the world, actually surgery up front still kind of a lot of people are still have the surgery without neoadjuvant treatment. So what is the role in this? What is the role of radiation therapy in this setting? So actually, in 2003, there's a randomized study published by a Chinese group. In there they enrolled about 500 patients. What they did is they compared adjuvant radiation therapy versus no adjuvant radiation therapy. What they did is they included the entire mediastinum and the bilateral supraclavicular foci, and the dose of radiation was 50 to 60 gray. And what they found is the post-operative radiation therapy improved 5 years survival in patients with high risk factor, which means they have stage 3 disease or positive lymph node. And another study actually also published recently included about 2,000 patients looking at surgery alone versus surgery plus radiation in nodal positive disease. So you can see, if a patient had a positive node, radiation therapy actually really improved the survival, especially in patients who had more than 3 positive lymph node. And that is the field they used. So very simple APPA and then oblique after 25 gray. How about adjuvant chemoradiation? So the chemoradiation, you can see, if a patient had a nodal positive, this is all nodal positive patients. This is post-operative radiation. This is post-surgery chemoradiation. You can see post-operative chemoradiation again compared to port again improved the survival. And also the number of cycles of chemotherapy made a big difference. The reason why adjuvant radiation therapy made a difference is because no matter the location of the primary tumor, because of the longitudinal travel of the lymphatics of the esophagus, the lymph node positivity is very, very high. Even this is in higher thoracic, of course, most of the lymph node travel superiorly. However, even if a patient had a lower thoracic esophageal cancer, you still have about 17% of patient has high neck or high thoracic or neck node. That's why it's important either give patient neoadjuvant or adjuvant if they have not had that. So for the adenocarcinoma, I think I'm going to skip it because I think it's very rare in this area. But the bottom line is the post-operative chemoradiation actually also improved the survival for patients with the GE junction tumor. And finally, what I want to touch base is a definitive concurrent chemoradiation therapy. And I talked about for single modality radiation alone, the outcome is very poor. This table actually summarizes some of our early findings. But I think the most important study to remember in definitive chemoradiation therapy is RTOG 8501. When we compared RT alone, 64 gray versus chemoradiation to 50 gray, and so this is this is the RT alone, and this is a concurrent chemoradiation therapy. You can see there's a significant survival benefit, and this trial actually, this arm actually was closed early, and the subsequent patients were all enrolled in concurrent chemoradiation arm, and the results was reproduced. And then from this study, you can see patient has very high local recurrence, as I just mentioned. The local recurrence actually is the major pattern of failure if patient did not have surgery or R0 resection. So that's the reason we had RTOG 9405 compare lower dose versus high dose. However, this study did not show any benefit of a high dose. That's the reason currently in United States, 50.4 gray is considered the standard of care. And you can see local failure after concurrent chemoradiation therapy in all phase 3 trials, and it ranged from 45 to about 60%. So actually, I think that is really, and also another study actually showed the local failure really happened, 90% of the time happens in the GTV, which means really is the primary tumor recurrence. And if a patient GTV is controlled versus not controlled, their survival is different as well. So that's why local control with a definitive chemoradiation is very important. Why it's important? You can see, you know, pathological complete response, very good survival. And if a patient had R0, R1 resection or residual tumor, you can see the difference, you know, the survival difference. So that is why I think, you know, in terms of esophageal cancer radiation therapy, we still have a long ways to go. We talked about radiation plays a very important role in the neoadjuvant, adjuvant, and definitive setting. However, after definitive chemoradiation therapy, local recurrence is very high, and we need to consider additional treatment. So radiation technical considerations, I think I'm going to skip for the sake of time. Thank you.